When I look at a week in the office, I think about 25% of my office visits have to do with something related to menopause. So whether it's irregular bleeding, hot flashes, vaginal dryness, this is a big part of a woman's life. And so I don't believe any woman would ever say that menopause really isn't that bad, because I think we all agree it has some downside. The difficulty for me is that I can't define menopause until after it's occurred. So by definition, medically, menopause is 1 year after you stop having your periods. And the real issues stem in this perimenopausal state, which can range anywhere from 6 months to 10 years. And in the United States, the average age of perimenopause is 47, and it's approximately 4 years in length for most people. Menopause, again, by definition, is 1 year after you stop having periods. And in the United States, the mean age is 51. There are some cultural and weight differences. So African Americans tend to go through the worst menopause, the most symptoms, hot flashes, while Asians have the least amount of difficulty, and Caucasians fall somewhere in between. And a lot of the possible treatments that I'm going to discuss with you in a little bit actually stem from the research that show that Asian women get through menopause without too many issues. So we also know that it's genetically predetermined. So when a woman comes into my office, I always ask how old their mother was or their older sisters, because it's likely that you will go through menopause at the same age your mother did. Nowadays, a lot of women have hysterectomies, so it's not always helpful, but I still do discuss it. And obesity is another issue that comes into play. The fat cells, the adipose cells, alter the thermoregulatory mechanism, meaning it doesn't help your body control body temperature. So obesity increases your risk of having hot flashes. Depression, anxiety, and smoking are also all related. So smokers go through menopause at an earlier age, and depression and anxiety also play into how severe the symptoms are. When a woman comes in, one of the first questions they usually ask me is, well, can't you just do a blood test to determine whether I'm in menopause? And it's frustrating, but the answer is no. So I know in menopause, or in the perimenopausal state, that estrogen and progesterone are going to decrease. I also know that something called follicle stimulating hormone, or FSH, increases. And that really is a hormone that the ovaries respond to. So if the ovaries aren't responding, your body's going to make more of that hormone to say, wake up and pay attention. The problem is to measure FSH, and that's what most women assume that I'm going to measure. It doesn't tell me how low your hormones are, how much estrogen or progesterone you might need, nor does it tell me when you're going through menopause. So I could get a high FSH level, and it could still be 10 years before you stop having cycles. So it really isn't all that beneficial. I can think of 2 cases that I actually really do get the lab, and it tells me a lot, and that's if a woman's been on birth control pills for contraception and comes into me at the age of 50. That's my max that I'll allow somebody to stay on pills. So I'll take them off and check an FSH to tell me if they're in menopause. The other is really helpful for breast cancer planning. So if a woman has been treated for breast cancer, letrozole or tamoxifen, some of the standard maintenance medications depend on what you get depends on whether you're in menopause. So in those women, I always get an FSH. So menopause, so the decline of ovarian function affects a lot of systems in the body, and most people are bothered by irregular periods. So that's the first thing in the perimenopausal state that begins to happen. And what happens is periods become heavier and closer before they start spacing out. So 50% of the visits in the perimenopausal state are about these irregular periods. Hot flushes or hot flashes are also bothersome, so they take up a lot of visits. Sleep disturbances, probably in relation to the hot flashes, mood symptoms, vaginal dryness, changes in cholesterol. And we really have to work with primary care because this is often forgotten, that when you lose estrogen, your lousy cholesterol or LDH is going to increase. And so you really have to pay attention to it. Bone loss and joint pain, and I don't think women are aware that joint pain can be significant in the perimenopausal state. So people assume it's because of arthritis, but it actually has to do with estrogen. And so it's surprising to a lot of women that you can experience significant joint pain, but it is one of the symptoms of perimenopause. And cognitive changes, memory loss, and difficulty concentrating. So all of these can be improved with treatments that I'm going to go over, but these are some of the things that women do experience. So hot flashes, we call them hot flushes. 50% of postmenopausal women experience them, and it ranges really anywhere from 60 to 90%. They're the most common symptom of perimenopause. If you look at women who do experience them, a third experience more than 10 a day, and that's quite a lot. And the worst time is actually in the perimenopausal state. So once you hit menopause and your periods stop, they progressively decrease. So you have about 20% of women who experience them after the 4 years of when their periods stop. What are they? They're characterized by a sudden sensation of extreme heat in the upper body, particularly the face. We really don't know what's responsible for these. We believe it has to do with norepinephrine and epinephrine. And the body has trouble maintaining a temperature regulation point. And again, the symptoms can last 6 months to 5 years. There are many different treatments that are possible. And for me as a physician, the goal of the treatment is to give you the least amount of treatment for the shortest amount of time. So whatever we're going to do, you start low and you do it for short amount of time to see if it helps. Estrogen and progesterone are the standard, so I'm gonna cover hormone replacement therapy, SSRIs, gabapentin, clonidine, herbal products, and soy, and we can go over that. When we talk about hot flashes, you always have to remember, it might sound simple, it's really important. Lifestyle modifications, so layered clothing, maintaining a lower ambient temperature, consuming cold drinks, avoiding alcohol and caffeine, and aerobic exercise. And aerobic exercise has been kind of controversial, but we do know it improves the overall well-being of a woman. So when a woman's working out, they feel better, and I believe the symptoms become less bothersome if they're feeling better about themselves. Antidepressants after progesterone and estrogen, so after hormones, antidepressants are actually found to be the most successful. And again, we don't know why they work, but we do know they target those epinephrine, norepinephrine. And we're using about half the dose that we use to treat depression. So while it's the same medication, the dosing is significantly less. And as a result, you get less side effects. So insomnia, dry mouth, constipation, those are all common with these antidepressants, but we're using about, again, half the dose, so they're less present less. The biggest one is actually Paxil, so that's been found to be the most effective, and it has the greatest reduction of symptoms. So Paxil, when a woman starts it, will reduce her symptoms by 63%. So that Paxil is the first antidepressant that will start. Lexapro is next, and that results in about a 55% reduction, and then Celexa. And just for an example, Paxil, the dose we start off is 12.5, so you'd never treat depression with that small of a dose, but it actually really works for hot flashes. Gabapentin is an anti-epileptic medication. It's one of the older medications. This is the only medication that actually decreases the severity of hot flashes. So it reduces the incidence by about 45%, but the severity decreases to half. The problem with this medication is you have to take it 3 times a day, so women who aren't good at remembering, it doesn't really work. And you can get some fatigue and dizziness with this. Clonidine is an anti-hypertensive medication. It's been around a long time. This is a great medication to use for hot flashes if the woman also has high blood pressure. And it's one of the older, more effective. Compared to estrogen, this decreases the hot flashes by about 30%, so that really only boils down to 1 a day. But if a woman only has a couple a day, that works quite well. There's many different herbal remedies, so if you look online and just Google it, a lot will come up. Black cohosh or black snake root has been the most studied. We have a very large study of about 400 women, and they followed them over 6 months of time. So with these, they work on the estrogen receptors, so you want to make sure the uterus is protected and there's no precancer or precancerous changes. And so we followed these women for 6 months and found that it is safe. Columbia is actually doing a huge study right now, and all they can say right now is that it is effective and safe. But that's all we know, really. It's hard to do studies on the herbal remedies because they're not FDA approved. So there's many different doses. And I don't have it up here, but vitamin E recently has been in the press, and that's also been shown to be effective. So my 2 top herbal would be the black cohosh or vitamin E. The others are not really worth the aggravation because they're not all that effective. Going back, remember when I told you that Asians have the least amount of hot flashes they get through perimenopause without very much incidence, and this initially we thought, well, they have a lot of soy in their diet, so maybe it's the soy that's preventing. And these phytoestrogens are plant substances that work on the estrogen receptors, and all of these foods contain the phytoestrogens, and I don't believe a woman can do poorly by adding soy to her diet. So in people it can work, and it's not harmful. It does have benefits for cholesterol and heart disease. So I am a big proponent of adding soy, whether it's soy milk, soybeans. And then just the success rate. So we talk about estrogen as having about a 90% success rate. The antidepressants are in the 60s. And soy just by itself will have a 40%, whereas if you take a placebo, so just like a sugar pill, women feel better 30% of the time. Soy can also improve vaginal dryness and memory as well. So those are the symptoms that are bothersome can be treated with soy. And I'm a big proponent of hormones, obviously. I advocated for my own mother to be on them. When I look at the patient population, there's very few people who cannot take hormones. I could think of four patients, and that's the presence of breast cancer, and that's really a contraindication for oral hormones. There are some people who still qualify for vaginal estrogen just because it's very little is absorbed systemically. If endometrial cancer, active blood clots, or pulmonary embolisms, and undiagnosed abnormal vaginal bleeding. So if a woman's having irregular cycles, I really just need to work them up before I put them on hormones to make sure something else isn't going on. Indications for hormone replacement when a woman comes in are the presence of hot flashes or vasomotor symptoms, vaginal dryness. There is literature if a woman has recurrent urinary tract infections to put them on estrogen cream that does decrease the incidence of urinary tract infections, and osteoporosis. And estrogen helps with absorption. It doesn't create new bone, but it helps with the loss. So approaches for therapy is really looking at the woman. You know, every situation is different, but again, I can't emphasize enough the lowest dose for the least amount of time. And the primary indication for hormone replacement is the treatment of moderate to severe menopausal symptoms. And there's really no number to define that. I could have a woman coming in with 10 hot flashes a day who's really not bothered, and then I have my next patient who has 2 at night and, you know, can't sleep. So it really is based on patient to patient. Estrogen for vaginal atrophy, and I'm not really covering vaginal dryness all that much, but it does play a significant part in menopause, and I think a lot of women are embarrassed to talk about it. It can lead to painful sex, bleeding, because as you lose estrogen, you lose the fat cells, and that area becomes very sensitive. So when I'm doing an annual exam on a woman in her 40s, 50s, 60s, I always emphasize the need for lubrication. And I make a joke that extra virgin olive oil is the best, but olive oil really does help preserve the function, and it works quite well. So the only time I give progesterone is when a woman has a uterus. So I see many women who have had a hysterectomy, and progesterone isn't indicated. So the indication for progesterone is endometrial protection. There are many regimens. So where I start depends on the woman's preferences and insurance. There's oral, patches, gels, creams, rings. So it just depends. Some women like a pill, some women don't. So it's based on patient to patient. Turning now, I want to cover a little bit about, in the lay press, there's been a lot since the 1990s about hormones being poor and bad and very dangerous, and I want to just quickly review the study on where that came about. So in the 1990s, there was a study called the Women's Health Initiative, and it was a clinical trial of looking at hormone therapy. It was published in the 1990s. It was very large, so it had about 65,000 women, and the goal of it was to look at hormones and how they related to chronic diseases, particularly cardiovascular. So the age of the women that were enrolled ranged from 50 to 79, and that's key because these women are a lot older than the women I put on hormones. So you don't see a 79-year-old going through menopause for the first time. So as we age, our risk of bad things also increases. So it was scheduled to conclude in 2005, and it was actually terminated in 2002 because of an increased risk of breast cancer, and then in 2005 the second part of the study was discontinued due to an increased risk of stroke. If you actually boil it down, and this is what I do when I discuss hormones, it's not all that different. I think the risk of hormones is very, very slim. So you look at, these are cardiovascular events, and when a woman is on hormones, there's 7 more events per 10,000 person years. So that's not all that significant. Strokes and pulmonary embolisms, 8% or 8 more per 10,000 person years. Invasive breast cancer, there's no risk until you're on hormones past the 5-year mark. So for the first 5 years a woman's on it, it doesn't increase her risk of breast cancer. Hormones are beneficial in that they decrease a woman's risk of colon cancer, as well as hip fractures. So those were the 2 positives that came out of this trial. And then, so this is just another view of that. Again, I think it's very difficult to generalize to the population that I'm treating because women are a lot younger than the age of at this study. And this really kind of shows the effects. So this is women on hormone replacement, and this is women not. And you can see that in 10,000 women years, the coronary artery disease risk off hormones is 30. You'll have 30 cases of coronary heart disease per 10,000. And when you're on hormones, it's 37. So, and you can see that really if you break it down to actual numbers, it's not all that different. Two neutral things that they ended up not saying. Initially they said hormones helped to improve memory, and studies since this time have kind of been mixed, so we can't really say that, nor can we say that it increases your risk of endometrial or ovarian cancer. Recommended reading. So there's a lot of things out there, and these are the books that I tend to recommend. Dr. Susan Love is a breast surgeon, and she wrote a great book on menopause and hormone, and so it's very easy reading. Dr. Northrope graduated from Tufts. She's kind of the guru. I think she actually, doesn't she practice in Maine? Yeah. Okay, so she wrote The Wisdom of Menopause. The V book has a lot on vaginal dryness. And then if you look up ACOG, or the American College of Obstetricians and Gynecologists online, they have a publication called Pause that's very good. One of the last things I just wanted to kind of touch on is bioidenticals. And when I was at Dartmouth, I had a lot of women coming in requesting bioidenticals. And these are plant-derived hormones that are chemically identical to the hormones in your body. So the hormones, some of the hormones that we prescribe and the ones that were done in the study are conjugated equine estrogen, meaning the estrogen is derived, it's made from the urine of pregnant horses. And so when women find that out, that they don't really want to take it. And so bioidenticals are more natural. And actually our lab here is quite good, and they do bioidentical testing. So you go in, you give a salivary, so they swab your mouth, and then they break it down and find out your estrogen progesterone component, and we create hormones that are identical to that. Problem is, again, that it's not FDA controlled, so some people think, it lacks validity. And alternatives, and one that I often start with, is estradiol and micronized progesterone. So these are the pills, the hormones that are most identical to the ones in your body. So without going through testing for bioidenticals, we can give you a concoction that's pretty identical. For some reason, people with peanut allergies can't take either of these medications. So. And that's it. I didn't know if anyone had questions.